A big hello to all of you out there. Welcome to this exclusive webinar series organized by the Indian Academy of Echocardiography. This educational series, which happens every 2 weeks, has been going on since a few months. So please make sure that you log into this regularly to update your what is the latest on echocardiography. Today we have a very distinguished speaker and an iconic person in the field of echocardiography. It is my pleasure to introduce to you Dr. Bijoy Khandheria from the Aurora St. Luke Medical Center in Milwaukee, Wisconsin, USA. He's also the director of echocardiography in the lab over there, as well as an adjunct clinical professor at the University of Wisconsin School of Medicine. He graduated from Baroda and then later on migrated to the USA and then worked at various hospitals and had a major stint at Mayo Clinic before he moved on to Aurora. Over the years, he has held many positions of eminence, one among being the first Indian origin president of the American Society of Echo. He has innumerable publications. He has been behind many guidelines and then written many chapters, textbooks. And on a personal note, I have to mention, he overcame a life-threatening illness a few years back, and his resilience and fighting qualities in overcoming this and coming back to clinical routine should be an inspiration to all. He's a familiar figure at the Indian Academy of Echo conferences, and in recognition of his achievements and constant support to IAE, an oration was instituted in his name many years back. Every year, this prestigious oration is held in his name at the annual conference of IAE. Coming to today's topic, Dr. Bijoy has been a pioneer in various areas of echo. T is an area where he has worked very closely. In the late 80s, he's been involved in some path-breaking data collection and then coming up with some research which has been part of the guidelines. So we have a person who is the ideal one to speak on T. So before I hand you over to Bijoy, just a few instructions to the online attendees. Please send in your queries, your comments, and any questions which you have in the comment box. We will address this at the end of the presentation. So over to you, Bijoy.
Thank you, Satish, and a very kind introduction. And as you and I were talking, the part about this is not being there and not being able to see everybody and be a part of everybody. Over the years, I've gotten to know many well-known echocardiographers in India. They always are a source of inspiration, and they are probably the ones who I use to inspire myself and say the end is not here, and I still have much more to do. So thank you very much. And the organizers of Indian Academy, my good friend Satish Parashar, thank you for having me do this. And today, what I'm going to do is share with you something that I thought was not something that anybody required to know, but I forgive for those of you who are pros, it may sound very basic, and for those of you who are not pros, at least an old dog will try to teach you some tricks or new tricks, and we'll go through it. So with that, I will share my screen, and I'm presuming, since I can't see what you're seeing, can you see the screen now, the slides? Satish, can you see?
Well. You can click.
Okay, perfect. So for this presentation, I don't have any conflicts or any off-label use. And I thought I'll start by sharing with you the common applications that we have seen since the 80s to now. And the most common application even today are those patients in whom the transthoracic imaging windows are not very easy to obtain. With the evolution of technology and the machines that we see, more and more you can get as good images from transthoracic, but then there are some patients in whom you cannot get them. So the largest one of the single most frequently utilized is when you can't get good transthoracic imaging windows. And as you can see on this slide, the rest of them are noted here. A couple of things that I will point out to you, that in the last 5 years, the huge growth of transesophageal echocardiography has been in the field of what I call as interventional echocardiography, or echocardiography done in the cardiac catheterization laboratory or the electrophysiology laboratory for structural heart disease and interventional procedures. I would, if you were to come to our lab, you would see that on a Monday, Wednesday, and Friday, we have one physician who is only doing echo TEEs in the cath lab, and they are doing it for mitral implantation, for left atrial occluders, for tricuspid valve, and for closing percutaneous leaks, and so on and so forth. So interventional echocardiography is something where transesophageal echo has really become. So as I was saying, that the biggest indication is interventional echocardiography, and is something that we do it very, very frequently. Let me just run over quickly the contraindications to doing transesophageal echo. And even the best person who is doing transesophageal echo, I would caution them not to do this procedure in individuals who have esophageal obstruction, like strictures or neoplasm, because that's where you run into trouble, and that's where you get the only deaths that have been reported from transesophageal echo are in those individuals. The other things are listed here, which are pretty simple and pretty easy to understand. There are some relative contraindications, which also I have listed on this slide. And the only thing that I would like to highlight is that if you have a patient who has a large diaphragmatic hernia, this is a patient that you would not want to do a TEE, because one may not get good images, not because you're not good at it, not because the machine is not the one, but it is because the diaphragmatic hernia precludes you from getting good images. If one wants to look at the safety of transesophageal echo, and this is more for the beginners, that really it is a very, very safe procedure. This is a very old paper, but still one of the largest numbers from Werner Daniel's lab, showing that the mortality rate from transesophageal echo was 0.0098%, which is very low. And the two cases that those who died were people who had unexplained esophageal tumors, and somebody put a probe in and they bled to death. And the other complications are really minor that you can see on this slide, which I won't belabor much here. So how do we prepare the patients? This is the protocol we use. This is the protocol that was used when I was at the Mayo Clinic. Patients are kept NPO unless it's an emergency room for aortic dissection, when you don't have the time. We do ask a brief history, and a history of dysphagia is one of the big ones that we will always ask for. A good IV access. Since February of this year, the ASC guidelines, the ACC guidelines have listed transesophageal echo as an aerosol generating procedure. So a pre-procedure COVID testing is recommended, and you have the ability of doing a rapid COVID test or a 2-day turnaround COVID test, but the but we do, at least the two societies do recommend doing a pre-procedure COVID testing for antigen. And if the person is positive, then we will ask the person to self-isolate. We don't repeat the COVID test, but we will bring them back in a week or 10 days. And there are going to be instances where they are positive, they need the test done for some reason that is essential. Then we do take them in the negative pressure room, which has the high HPEF, the filters, and the person doing the study is appropriately wearing the protective equipment, and we will do it. But that's a new thing that I thought I'll bring to your attention, that is being at least practiced in institutions here. And the rest of it is pretty clear to all of you and pretty obvious. We do use generous amounts of fentanyl and midazolam and topical spray with lidocaine. The indication to give them prophylactic antibiotics is a class 3 indication. This came out from the American Heart Association in 2007. And I thought I'll also share that with you, that there is really no antibiotic prophylaxis required for transesophageal echo. Some tips. One, that keep in mind that the transducers are as small as 9 millimeters and as large as 14 millimeters. Remember that don't panic if you don't get pictures, because from the mouth to the esophagus is around 30 centimeters. So if you're just inside the mouth and you've just inserted the transducer and you don't get the pictures, it's not a cause for panic. Only time you panic is when the patient then starts desaturating or starts wheezing. Then you know you've not entered the esophagus, you've entered the respiratory system. I always teach my colleagues, my junior attendings, my fellows, that this is not where you need to exercise your upper extremity, that gentle manipulation is better than excessive manipulation. It will avoid tears, perforations, and you will be happier at the end of the procedure. So excessive manipulation of the probe is to be avoided. And if you're using multiplane probes, you really don't need to be moving the probe back and forth, up and down, because everything can be done electronically using the multiplane now, transducer. This is from the ASC document, which just kind of goes through what the movements are. You can move the probe, you can advance it, you can withdraw it, you turn it to the right, you turn it to the left, you can rotate the probe posteriorly for the aorta, and then you have anteflexion and retroflexion of the probe, and right movement and left movement by the small knob on the probe, and the big knob is the one that you use to anteflex and retroflex the probe. These are the views, and I'm not going to belabor it. If you all want to read it, it was published in the Journal of American Society of Echocardiography, but I'm going to show you all of the views and what are the pros and cons of getting each one of the views, and let you look at it. So the several of the videos coming up are from my days at the Mayo Clinic when we had produced these videos, and I'm using them to share with you. So this is on a multiplane that 0 degrees, 45 degrees, 90 degrees, 135 degrees, and 180. These are the common angles that one will use to get most of the cardiac anatomy. They are not necessarily always at these angles, because as you know, it all depends on the position of the heart. But by and large, if you're at these angles, you can get most of the views that I'm going to share with you with a little manipulation of the probe with flexion or rightward or leftward movement. So let's look through these animated videos. Everybody has a style. When I do these procedures, I go transgastric first and then come up and look at the rest of the heart. So what I'm going to show you are all the views that I will obtain when I'm in the transgastric position. And I'll just let you watch each one of the videos. So here now you can see on the animation that I'm in the transgastric or fundus of the stomach. And the first view I'll try to get is a short axis of the left ventricle. That gives me quite a bit of information. It shows me the anterior wall, the inferior wall, the lateral wall, and the ventricular septum. It's a good view to use when you are monitoring patients for ischemia. It's a good view to use for everything that we do, because this gives us an idea of what the left ventricular systolic function is. And this is a view that is at papillary muscle level, that you get it at 0 degrees. You need to flex the transducer so that you're bringing the probe close to the fundus of the esophagus and be able to scan, as you can see in this animation. Then what I will do is I will pull the probe a little bit, I'll still keep it in the fundus, but move it just a little bit, as you can see, by rotating the probe a little bit. And then you can get a view, which is the basal short axis view, as you can see in this video, where you can see the papillary muscles, and you can see the mitral valve in a basal short axis view, very similar to what we would be getting from a transthoracic. And this view is not very difficult to obtain. It just needs a little gentle withdrawing of the probe and a little more flexion, and you get this view from 0 degrees without having to change much. The next thing is the long axis of the aortic valve, and every so often, if you're doing a TAVR or an aortic valve is difficult to get, this would be one of the views I would recommend. It doesn't really need to be done in every patient, but you anti-flex, which means you turn the knob clockwise, and you can see the aortic valve very nicely in this example, right in the center. And this is a view that you can get by anti-flexing the transducer. This is also a view where you can do a CW Doppler for assessing the severity of aortic stenosis if one is not able to get it by transthoracic echocardiography. We now go to the short axis of the left ventricle, because the apical short axis is important to get, but we don't get the true apex from transesophageal echo. You get a little bit that looks like an apex, and you can here see that you see the liver at the top, you see almost close to the apex, and you also see the right ventricle. So the left ventricle was on the right side, and the left ventricle was on the right side. And this view again is important when you're looking for ischemia, or if you were doing a percutaneous mitral valve and you wanted to see if there was any residual apical damage from a percutaneous mitral valve. But this is a view that one can get, requires you to advance the probe and just a little anti-flexion of the probe, but towards the apex, as you can see. The deep transgastric view was very popular in the old days. It's really not required most of the times, but if you're struggling to get the aortic velocity, you advance the probe further into the fundus of the stomach, and you anti-flex it as much as you can, and you get a view which is a deep transgastric view. Again, a good view for putting a CW Doppler to get the peak aortic velocity, and also to get the LVOT velocity with a pulse Doppler if you so desire. Not very frequently used because most of the aortic measurements can be obtained by transthoracic, but in those difficult cases, this is a view that one would consider getting. The next view from the would be the long axis view of the left ventricle. And you can see here that we have now rotated the angle from 0 to 80 degrees or between 80 and 100 degrees. And you can see the long axis. Long axis is very good if you want to see the mitral valve, you want to see the papillary muscle, and you want to look at the wall motion, as you can see in that echocardiogram that we just played. The next one is the long axis view of the left ventricular outflow tract, which is around 100 to 135 degrees, was used for TAVRs. These days, it is used very much for mitral implantation because you don't want the mitral valve to be encroaching into the LVOT. And here you can see that long axis view of the left ventricular outflow tract with the aortic valve. So these are the transgastric views that we get. And if you're doing a lot of tricuspid valve evaluation, or if you're doing tricuspid valve clips or tricuspid valve percutaneous replacement, then this right ventricular inflow view, which one gets at 120 to 140 degrees is the view that you would use, as you can see in this example here. And you can see the right ventricle, and you can see the right atrium and the tricuspid valve and the liver on the top. And this is a view that one would use for anything to do with the tricuspid valve view. If you rotate, or if you bring the angle back to 0 degrees, you would get a short axis view of the tricuspid valve. And this is a view that would be pretty useful in congenital conditions or in interventions in the congenital heart disease world. But you can get the tricuspid valve also at 0 degrees. The next step would be then to come to the mid-esophageal views. So we finished all the transgastric. I will pull the probe out to the mid-esophageal or mid-esophageal level, as you can see in this animation that I'm now pulling the probe, and we are at 0 degrees. Never pull the probe with anti-flexion, let it be in the neutral position. And when you are in the mid-esophageal view, you will see a 4-chamber view. Now, some people start with the 4-chamber view because it gives you an orientation of the heart, and there's nothing wrong with starting here and then doing the rest of the views. But this is a view, most commonly utilized view. It's at 0 degrees, and you see the left and the right ventricle very nicely. For mitral valve evaluation, you get to the 2-chamber, which is now you go to around 60 degrees without moving the transducer. Just rotate the angle to 60 degrees. And when you are at 60 degrees, you get the 2-chamber view. Again, very, very familiar to you. Can get a look at the early look at the left atrial appendage, which was on your right-hand side, as you saw. This is also the view that one would utilize for looking at commissures of the mitral valve, which is again important for mitral valve procedures. So from this 2-chamber view, one would then go to left ventricular inflow view, which is around 90 degrees. And at 90 degrees, you can see the left atrial appendage. You can see the Q-tip or the ridge of the pulmonary vein coming into the left atrium. And you can also see the left ventricular inflow in this view. Right ventricular outflow tract view, you want to rotate the transducer a little bit and keep it at 90 degrees. And this is what one would see for the right ventricular inflow view. And this is again used for procedures on the right ventricle, but also used to look for other pathologies. And you can see here a little bit of the pulmonary artery. It would be something also we would look for various kinds of shunts on this one. We then keep it at 90 degrees, but rotate the transducer more rightward. So just turn the transducer without doing anything. And what we will get is the view of the ascending aorta, good for aortic dissection, good for measuring the LVOT diameter. And here you can see the ascending aorta nicely in this view. And this is a view that you would get again from the mid-esophageal position. The bicaval view, very, very important to look for masses, to look for atrial septal defects, for patent foramen ovale, or during closure of PFO or ASD. And this is again at 90 degrees and then you rotate the transducer a little more rightward, and you'll get the bicaval view. Like you can see here, this is a patient who has an atrial septal defect. You can see the shunt. You can see the inferior and the superior vena cava right here. A view for puncture, transeptal puncture, a view for ASDs, a view for PFO, a view for a percutaneous placement of closure devices, atrial septal defect closure devices as well. There's also a view that you would look if there was a PICC line or a subclavian catheter or something, and you are looking for lesions in the right atrium. Still in the mid-esophagus, we go to 120 or 135 degrees, and you will see the long axis of the left ventricle and the aortic valve. Again, something that is very commonly utilized for TAVR percutaneous placement, and for measuring the LVOT diameter if you are unable to measure it from transthoracic echo, as you saw in this particular picture. The next view is also very important, which is the short axis of the aortic valve. And from the same position, you go to 45 degrees. And at 45 degrees, without doing too much or a little bit of anti-flexion, you'll be able to see the short axis of the aortic valve and know whether it's a bileaflet, trileaflet, unicuspid aortic valve, as you can see in this particular example. This is an example of a trileaflet aortic valve. The other big indication for transesophageal echo is to look at the left atrial appendage, whether it is prior to cardioversion, whether it is for a thrombus, or whether it is for sizing of different occluder devices like Watchman, M-Platzer, or any other occluder devices. 45 degrees, and we should be able to see from the mid-esophagus. As you can see here, this is the left atrial appendage with the left upper pulmonary vein in the far right with that little bulb, which is the Coumadin ridge as it's popularly called, but it's where the entry of the pulmonary vein is into the left atrium. So this is one view where you look at the left atrial appendage around 45 degrees, may require a little bit of anti-flexion, but still from the mid-esophageal view. Then once you have identified the left atrial appendage, what I do is I just rotate the angle to 90 degrees, and I want to see the left atrial appendage in 90 degrees. And these measurements become very important if you're doing a left atrial appendage occluder or if you're looking for hidden thrombi. So this is the left atrial appendage from the 90 degree. Generally, the longest length of the left atrial appendage is at 90 degrees, and the longest width of the left atrial appendage is at 130 degrees or 135 degrees. When I'm looking at the left atrial appendage, then I'll also look at the left upper pulmonary vein and right lower pulmonary vein by just a little twist and a rotation of the probe, not necessarily flexing or retroflexing, but just a rotation. And here you can see both the pulmonary veins entering very nicely. Color flow, you can get the pulmonary venous Doppler if you so desire. But again, this is a view that you can obtain universally in the large majority of the patients from this angle. Having looked at that, we want to look at the left upper and left lower pulmonary vein. And again, that one is from the left atrial appendage view. You can anti-flex a little bit and move the angle to around 5 degrees here and there, and you should be able to see both the pulmonary veins, the left and the left upper and the left lower pulmonary veins. Pulmonary artery bifurcation is done when you have the probe at around the left atrial appendage. You pull it up a little bit, and then you are at 0 degrees, a little bit of anti-flexion, and you see the pulmonary trunk, and you see the bifurcation of the pulmonary artery, the right and the left main pulmonary artery, and you can see, you can use this for measuring, plus you can use this to look for big pulmonary emboli or pulmonary thrombus. Right pulmonary artery, you can get it from 0 degrees by just moving the transducer clockwise. And as you are scanning, you'll find this move, the rightward movement, and you can then see the right pulmonary artery very nicely. Aorta is in the center, and you can see as in this patient, there was a catheter in the right pulmonary artery that you just saw brief glimpses of. All of these are from the mid-esophageal view or a little higher esophageal view. And then what you do is, if you want to see the aorta, you turn the transducer to the left or posteriorly, which is a counterclockwise rotation, and then you can see the thoracic aorta. And as you see the thoracic aorta, then you can keep pulling the transducer up till you lose the aorta. So you can see the descending aorta, you can see where the arch comes down, and then to see the arch, you would have to rotate the transducer as you're pulling it up. And that's a little difficult thing to do, but you can do that. You just have to be gentle. You keep pulling it up, and as you see the aorta, you keep following the aorta till you see as much portion of the aorta as possible. This is looking at the descending thoracic aorta, and then this is kind of looking up and down the aorta to be able to see the entirety of the descending thoracic aorta. Done at 0 degrees, doesn't require any flexion, just moving up and down the esophagus. So here is a 75-year-old asymptomatic male who had aortic valve replacement, and this is his echocardiogram. I apologize that we don't have an audience response system, but as you can see, there is a problem here. There is a systolic expansion of where the aorta and the valve was inserted. And when you see the color flow, you can see that there is a flow from that cavity or from that bulge into the left ventricular outflow tract. This is abnormal. This was a patient who had aortic abscess, which then ruptured, and you can see the fistula very nicely into the left ventricular outflow tract. And you can see the views that we used, which are the long axis, just as we had gone through. But this is an example of a pathology, an abnormal aortic valve with a fistula. So then this is a patient who has multiple vegetations. You can see on the aortic valve, this is a native valve, and aortic valve, you can see that shaggy looking material with a prolapse. And then on the mitral valve, on the anterior leaflet, you can also see a shaggy looking structure with a tail-like structure that is going into the left atrium. And this is an example of a patient who has bad infection and has infected both the mitral and the aortic valve. And as you saw, this is one of the common indications is to look for vegetations, and vegetations are seen here, and these are some of the features of vegetation as listed on this particular slide. So this is a patient who has fever, is being given antibiotics, and you can see that this is an example. So the first one I showed you was an example of where there was a fistula. Now here, this is a patient who has an abscess, an aortic annular abscess from endocarditis. And on the right-hand side, you can see the turbulent flow, you can see the eccentric jet, and then that systolic bulge is also very, very evident with flow inside it. So there's been a rupture of the aortic annulus, and that abscess cavity, you can see the flow going back and forth into that abscess cavity. So this is an example of an annular abscess, not a good thing to have. Explains why this fever is why this patient is persistently febrile, which is the most common reason would be that the patient is constantly, the antibiotics don't get to the annulus, and therefore this is an indication for surgery in this particular patient. So example of an aortic annular abscess. So there's a 60-year-old woman who has hypertension, and she presents with syncope. So now we are looking at the long axis of the aortic valve and the long axis of the ascending aorta. And this is also for even the advanced echocardiographers, but also new ones. You must carefully look at everything. And what strikes me is this unusual thickening here with this echolucent area. And when you see this, it may not be the complete diagnosis we get from transesophageal echo, and this is a patient I would definitely want to do a CT scan of the aorta, but you can see on the right-hand side that there is a echolucent area, a bright area, and then the bright area. So this is what has been described as the 3 layers, and this is an example of an intramural hematoma that would explain symptoms commonly occurs in hypertensives. This can then rupture, this can perforate, and this can result in also death. But intramural hematoma was described by the Germans with a 3-layer appearance, and my mentor, Dr. Tajik, would always say that if the brain doesn't know, the eyes don't see. And this is an example of looking very carefully. A 60-year-old, we should not say that, this looks normal because it's got that tri-layer appearance. And this is an example of an intramural hematoma that then was confirmed on a CT scan. Intramural hematomas have a very bad prognosis. So therefore, these are individuals that you would want to get a CT surgeon to see. And in many instances, we actually have replaced, or the surgeons have replaced the aorta because the incidence of perforation, aortic dissection is very high in these individuals. So an example of an intramural hematoma for you to keep in mind as you are navigating through transesophageal echo. So here is a patient who we did, 78 years of age, who came in prior to cardioversion, and it doesn't require too much of imagination that you see that gelatinous material in the left atrial appendage. You can see that there is a tiny thrombus at the tip of the left atrial appendage. And also these are all pectinate muscles, but here is that smoke-like, but it's not really smoke. It's more like jello that is a pre-thrombotic or a real thrombotic material, soft thrombus right here. But this is one that you would obviously want to consider deferring cardioversion, because these are patients who, when you stun the left atrium by cardioverting them, these are patients who are going to end up having a post cardioversion day 1, day 2, day 3 embolic event. And when you see this in the pre-cardioversion echo, you want to intensify their anticoagulation and then reconsider cardioversion here. So this is one of the beauties of multiplane transesophageal echo. You can see that there is a small lobe that is tucked in here. And when you see this thrombus may not be in the body of the left atrial appendage, but you can see that there is a tiny thrombus that is hidden away in the posterior lobe of the left atrial appendage. And you need to be looking at the left atrial appendage at 0 degrees, 90 degrees, and 135 degrees. And these little finger-like appendages are all seen when you are at a different angle. In this case, it was around 80 degrees. Thrombi the body of the left atrial appendage may look normal, but when you find this lobe, you may see a thrombus in there. And unless we interrogate the left atrial appendage carefully using multiplanar imaging, we could miss a thrombus, and the consequences could be very bad. So this is an example of a patient who has a thrombus tucked into that posterior lobe of the left atrial appendage. Here is another example where it looks fairly clean here, but you start seeing some funny thing. And then when you go to 100 or 110 degrees, you start seeing a thrombus hidden in this lobe of the left atrial appendage. So again, important point to make here is that left atrial appendages are multi-lobed. In the study that we published, 66% of left atrial appendage had more than 2 lobes. And hence, when we are doing a TEE for left atrial appendage, we should look carefully at all the lobes, or at least try to find all the lobes. And if you're doing an occluder device, it is also very important, because you want to measure the width of the left atrial appendage, the length of the left atrial appendage from different angles, and that will help you size the device. As you know, most of the occluder devices come in 3 sizes only. So which one to use, you convert it based on the measurements that you are getting from the highest length or the longest length to the biggest depth. But you can see a thrombus right here. You can see a thrombus right here. Again, an example of why multiplane becomes an important modality to use. So here is the traditional look at the left atrial appendage. And you can again see a spontaneous echo contrast, and you can see the thrombus that is hidden in this left atrial appendage. And this is what has been described as smoke or spontaneous echo contrast, as the case may be. But again, don't just get fooled by the smoke. Where there is smoke, there is likely to be fire. And we should look for the fire, which is a little more dangerous than the smoke itself, as you can see in this particular example. So with that, I am going to stop talking and let you entertain any questions or whatever else you want to ask. And Satish, maybe I should just turn it over to you.
Hi, Bijoy. That was quite an interesting set of images. There have been a couple of queries. So I guess before we start on the images which you have shown, let me sort of try and look at these queries as to what they are sort of inquiring about. So there is one particular gentleman who has asked whether he has this particular style where he does the mid-esophageal first, and then he goes to the upper esophageal, and then he comes down to the transgastric, and he just wants to know whether it is correct. So I guess it all depends on a few things. It depends on what is the nature of your study and which is the priority which you have. I guess you will have to finish with that. And then depending on how you feel the importance of the upper esophageal or the transgastric, you can go for it. But the natural flow is that the upper esophageal always comes at the time when you're withdrawing. So I guess if you really look at it, probably you could do the transgastric if it is really required. And then once you've done the mid-esophageal, and then once you're pulling it out, you can look at the aorta and then totally take it out. What do you think of that,
Satish, I agree with you. It's like I said, it's an individual style. The point that you made, which I want to emphasize, is that when you come to the upper esophageal view, that's when the patient starts coughing. That's when it gets difficult for the patient. So if you were going to, or if I was going to perform a transgastric, I would do it after the mid-esophageal. I would go for the transgastric and then do the upper esophageal, because when the patient starts coughing, then, you know, it's not comfortable for the patient. It's not comfortable for the examiner. But there is nothing wrong in starting with the mid-esophageal view. And the other point I would emphasize, which you also made, is that yes, transgastric view is not absolutely required. And if you have spent 15 minutes from the mid-esophagus getting everything you want, you can abbreviate your examination and not do the transgastric if that's not an indication. And one thing that I didn't emphasize, which you did, and again, my apologies, I should have, is that transesophageal, unlike transthoracic, doesn't need to be a 45-minute exam. It should be focused, but not such that you kind of put the probe in and take it out. If it is endocarditis of the mitral valve, take 5 minutes to look at the mitral valve, look at the annulus of the mitral valve, make sure you're looking at the intervalvular fibrosa, because you want to pick up all the subtle abnormalities that you would not have picked up. And don't think that I need to get my transgastric, so I need to hurry up on it. And it's, as you rightly pointed out, it's an exam where you want to focus on the pathology or suspected pathology, exclude that before making it a complete exam. And you don't have to do everything. So that gentleman or lady who asked the question, nothing wrong in doing it. And the way, I mean, you really made key points here.
The other point which I wish to make for the viewers is that generally in India, we tend to do the TEs without any sedation. So sedation is used in a very limited percentage of patients. So generally the time which is there available is very less. And at some point of time, the threshold of the tolerance of the patient comes down and they start to become uncomfortable. So I guess just to emphasize, go for the first and foremost, what exactly the reason why you're doing the TE, and then you can spend the remaining time looking at the other areas. Unlike in the in the West, where they do sedate the patients. It is a must. But here we have our own sort of approach, which has its limitations, but there are a lot of practicalities involved.
I totally agree with you. Where I trained how to do TEEs in Germany with Professor Erbel, and it was a total shock because we would do 10 TEEs and none of them would be sedated. But Germans, as I learned by nature, if the professor told you you will cough, but that's okay, they would cough and you could do the exam. I was learning from him. So he would do the exam, then I would do the exam. And I just thought that, boy, these patients are just phenomenal because they would let me do 10 minutes of exam unsedated. But the basic rule that you pointed out is go for the money. That's what bank robbers do. They don't go and rob a bank if they know that there is no money there. So you go for the money. And clearly what you pointed out is very, very true, except one place, which is in the interventional arena. So if you're in the cath lab, most of these patients are sedated. And in a structural heart disease in the interventional arena, there are no shortcuts because, at least in the US, TEE has become the mainstay. And if you mess up, the interventional cardiologist will kill you because you messed up, since they are totally blind most of the times in big mitral interventions, tricuspid interventions, left atrial occluder. The fluoroscopy doesn't give you the same thing that an echo does. So that's the only time where I would say, don't miss something.
Yes, that's a very good point. Moving on to another question. This is from another gentleman. He has a question where, is there any necessity for endoscopy or CT to rule out esophageal disorders before the T to look for any contraindications? I guess in a practical sort of way, nobody does these things in a routine manner. But if there is any suspicion, I guess we go beyond and then start investigating. But on a routine basis, there is no need for endoscopy to be done as a pre-T workup.
I would agree with you, unless you are in private practice and it's a rich patient and you are running low on your finances, then you can do it. But it's not medically, it's not indicated.
Yes, yes. Another gentleman has made a point that which we also agree, and which Dr. Bijoy has made, that when you're looking at the left atrial appendage, there are multiple lobes, and as you very clearly pointed out, and as this gentleman also, the viewer, has made, is that we need to look at the left atrial appendage from multiple views, look at multiple lobes. So we agree with your point, and absolutely you have to look at it from different views. Now, the next question, I guess I will put it across to you, Bijoy. This is a bit of a structural intervention query. This is about VSD closure. So how do you differentiate between a supracrystal VSD and a leak after device placement for RSOV aneurysm? And this is purely by 2D-T. So supracrystal VSD and leak, how do you differentiate after device placement for ruptured sinus of Valsalva aneurysm?
So first, it should not be happening. It's a rare complication. So if you have seen it, send it to European Journal Cardiovascular Imaging. It will make it to image focus because it doesn't happen very commonly. But secondly, from the limited experience I have, it's not something I would diagnose on a transesophageal echo. I would be utilizing more of a transthoracic transesophageal combination. If you remember, the LV OT view or the LV aortic valve view. If you get to that view and you antiflex it a little bit more to bring out the supracrystal portion of the ventricular septal defect, and then you put color flow, there should not be flow going into the into the right atrium when you have closed it. So that would be the way I would diagnose. But I honestly don't do enough of these congenital, and I've never not done enough of these congenital closures. So I'm not the right person to answer that.
Okay.
I could name several well-known people in India who do more of these than all of America, and they may be the right people to answer it. So.
This is a question which I guess which was waiting to happen. So it's about the use of 3DT. So this particular question pertains to does it improve outcomes? Does it improve diagnostic accuracy, especially the newer ones which have these true views? You have these light source which have become very sort of popular. So I guess from my personal perspective, yes, it definitely indeed it improves outcomes and definitely the diagnostic accuracy. So the message is that those who can afford to switch over from 2D to 3D, please go ahead. 3DT is here to stay. It does have incremental value. It improves outcomes, especially when it comes to device closures, and also to look at diagnostic when you have diagnostic challenges like paravalvular leak. So these are the areas where 3D really sort of makes a difference. Your comment on that, Bijoy?
Satish, I would totally agree with you. I actually would be surprised that in 2020, any manufacturer would be selling a probe that is not a 3D probe, because there'll never be a study, a randomized clinical trial proving 3D over 2D, but those of us who do 3Ds, whether it's transthoracic or transesophageal, know that it does enhance the accuracy. And Roberto Lang has published some of the work in mitral valve, in aortic valve, and in tricuspid valve for valvular heart disease, no questions about it. I do believe that some of the fancy stuff on 3D that does raise the cost of a machine or a probe does not or has not been proven yet such that you should invest in it. But a standard 3D with all of the features that you just described, I think it's absolutely essential. The other thing about a 3D TEE probe is that if the patient is uncomfortable, you can grab the full volume, and you need to grab only 3 full volumes or 4 full volumes. That means the procedure becomes very short. And then you can sit down and take that full volume and look at the structure as often as you want. Your surgeon says, I want to look at it from the left atrium. You can cut it and look at it in the left atrium, because you have now collected the heart, so as to speak, and you can look at it any which way that you want to. So that's a big advantage also for diagnostic imaging. So I would wholeheartedly agree with you that today 3D is not something that only Roberto Lang uses, but it's something that would be very, very useful, and completely agree with you.
So it is worth investing for the viewers to switch over to the 3DT, especially those of you who are doing large numbers or in places where they're doing challenging interventions, or where you do come across challenging diseases. Now, the next query is about 3DT again. And this is about what would be the ideal way of acquiring a 3D data set for looking at the tricuspid valve especially these days, there is a lot of work on the tricuspid annulus. So this is even I face challenges when I'm doing 3DT, especially the tricuspid valve. So do you have a particular suggestion, a good suggestion for this query, Bijoy?
Yep. It's an excellent question. And, we are a part of this Illuminate trial and also the tricuspid clip trial. So it's not my idea, but it is something that all the experts who do the tricuspid valve intervention put together, and they came up with a series of views on 2D and 3D that are mandatory if you're going to recruit patients and put them in the trial. So if you remember, I showed some views of the tricuspid valve. Couple of them were transgastric and couple of them were mid-esophageal. If you get any one of those views and you grab the full volume from there, then you can do the shading. And this is also where the true view and the light source and everything becomes very important. So those are the views that I would get. The tricuspid inflow view from the mid-esophageal would be one view that is absolutely required. The short axis of the tricuspid valve, which is a tougher view to get, but from transgastric, when you grab a full volume from that, then you can, look at it, because the Tri-Illuminate requires you to look at all the leaflets. The clip requires you to look at the leaflet from the atrial surface and the ventricular surface. So those views actually have been published, and Becky Hahn is the author who put it together with a multiple echocardiographers and interventional cardiologists. And the three key views would be the right ventricular inflow view that I showed you, the transgastric right ventricular short axis view, and a good 4-chamber view, but more focusing on the right ventricle. So you may have to pull the probe up just a little bit and then rotate it right-sided so that you get the tricuspid view. I must say that the screening protocol for any of these two trials that we are doing in the US, the bulk of it is from transthoracic. And it is much easier to obtain these views from the transthoracic than it is from the transesophageal. And in transesophageal, if it's an unsedated patient, they are very uncomfortable. Both of these protocols require 90 clips from a transesophageal. 90 clips doesn't mean 5 minutes, it means 45 minutes, 50 minutes. So these are patients, at least at our place, we actually use an anesthesiologist and use propofol, because otherwise it's very, very uncomfortable. But transthoracic is generally, we start with a transthoracic because that's what the protocol requires. Transthoracic right ventricular inflow view, transthoracic short axis view with a focus on the right ventricle. Pretty much all the guidelines that are recommended by ASE for transthoracic is one of the ways. Just recently, we've also found that we actually put these patients in a prone position, and you get beautiful transthoracic right ventricular views. We just published it 3 weeks ago in the Journal of American Society of Echo on how to get them. We started doing it for COVID, but we ended up that this is also something that you can do to get the right ventricular views. But it's a very difficult and a challenging one. And I apologize that I can't tell you much more than that, but those 3 views that I showed is where I would get the full volume and then learn how to manipulate that full volume.
So I do hope that answers excellent points which Bijoy made, and that answers the question raised by this particular gentleman. So now let's move on to another query here. This is a question about something which Bijoy did well in the early part of his presentation. Which view is commonly used for aortic valve Doppler profiles? Is it transgastric long axis or deep transgastric? Well, I guess both could be useful depending on how well your cursor is parallel to the flow. So pick the one which is where you feel that this particular view provides you the best profile. So either you can go for the long axis or for the deep transgastric. So between the two, you can choose any one of them. Bijoy?
Agree with you.
Okay. This is a different one. How do we successfully carry out a Valsalva maneuver during TE, especially when you have to rule out patent foramen ovale? So that is the first question. So let's take that first question. So I guess what I would suggest is that if you are planning to carry out Valsalva during the TE, so it is always good to have a few minutes talk with the patient and practice a bit of a dummy run, explain that you're going to do this maneuver and you would like to make the patient cough or do a little bit of straining. So you can sort of try and get the patient's cooperation as much as possible. It's always a difficult thing when you're doing a Valsalva during TE, but that is, I think, a very basic requirement before you actually sort of start to do the Valsalva. Bijoy on that?
Yeah, so another trick that we have learned over the years now is that we actually, because again, the logistics may be somewhat different, but what you said makes a lot, is how we would do it. The other thing is that we actually have a nurse in the TE room because we sedate these patients. So what we do is that we actually have the nurse apply abdominal pressure. And because some patients who are sedated cannot do a good Valsalva. So we apply abdominal pressure and then have them release it, which also raises the intrathoracic pressure and gives a similar, probably not the same, but a similar outcome for looking for PFO and a shunt. But I'm too old fashioned, but I do what you explained, that I explain to the patient that it'll be required, it'll be uncomfortable, and that I typically do the Valsalva towards the end of the TEE procedure rather than towards the beginning of the procedure, so that if the patient is coughing, and those are the times when you want the patient to be really coughing because that's the Valsalva itself. So.
Okay. The next question is from the same person. So this is a bit of an unusual question here. So, and the use of tea during CPR. So what are your views? So that is the general sort of a query. So I guess the use of tea is very, very sort of limited unless you're in a critical care, well-organized unit where you have a probe in place or when you can sort of afford to put the tea. So the one advantage is that you get to see an unimpeded view of what's happening. And also there has been some data on how you can sort of guide the compressions, also how effective the compressions are. So just my 2 comments on that, Bijoy, from your side.
I would say it's very infrequently utilized, but is catching on because at least in the US, intensivists are starting to do TEEs. So when they are doing TEEs, they do use it not very frequently because TEE, as one of my colleagues tells me, is a nuisance while they are trying to resuscitate the patient, etc. But it does allow you to look at the ventricle much better and decide if your compressions are working or not working. It's really not in the early days of TE when everything was being explored, it was utilized more frequently, more to learn more about it. But as you appropriately and aptly pointed out, it's not, you need well-organized units, you need everything to be in place. It's I can count the number of times that it has been utilized in Aurora in the last 10 years, and also the last 20 years at Mayo that I was there.
Okay, that's the next question is on the left atrial appendage velocity. So this, what is the importance? This is the question. I would say that in every patient, wherever, especially when it is clinically indicated, there should be a mention of the left atrial appendage velocity. It is something which is very easy to obtain, and it gives you information of how well the appendage is contracting, and it is old data, well established, and so it is very, very useful, especially if you're looking at patients where they've had left atrial fibrillation, or looking at the other types of diseases where you think that the left atrial appendage is involved, left atrial dilatation. So the importance of left atrial appendage is there, and you should do it as frequently as possible. Your suggestion on?
Yeah, I would agree with you. I think I would only add that do it in every patient, because when you need to do it, it may be difficult, but if you've done it as a routine, and it takes less than few seconds to do it if you're looking at the left atrial appendage. And we know from data from Cleveland Clinic, Alan Klein's work, that low left atrial appendage velocities portend bad things, and normal left atrial appendage velocities portend good things. So yes, our sonographers also try to obtain it even by transthoracic if they can see the left atrial appendage.
So there are your viewers. So please do it. So for every patient, do the left atrial appendage velocity. This is from another viewer. So is there any need of hemodynamic stability before T? So I guess that's a question where, of course, if you are going to do T, you need to keep the patient as hemodynamically stable as possible. But you have situations where you need to do the T in an unstable patient. So you do take care of all the supportive infrastructure which is there around you. And then you, after that, you sort of do the transesophageal echo. So the question, Bijoy, hemodynamic stability before T.
Yeah, I would agree with you. I think there are some situations where you're called to do a TE because the patient is hemodynamically unstable. So at least in my experience, I don't postpone a TE, but I do take advantage of all the infrastructure and make sure that if the blood pressure is 60, I want to make sure that the blood pressure is stabilized, or there are inotropic drugs. And it also brings back what you earlier had said, that these are also places where you want to do a focused TEE, because you want to look for what is causing the hemodynamic instability. But it's not a contraindication, but for the examiner, it's good if the pressures are, if the patient is hemodynamically stable, or you try to stabilize them as good as it is required anyway.
Okay. This is from a person who probably is doing a lot of 3DT. So it's a very sort of focused question on 3DT. So what settings would you suggest, would you advise when you are doing 3D vena contracta area for mitral regurgitation or tricuspid regurgitation in terms of filters? And would it be a full volume Zoom? So any tips for vena contracta, especially if there are multiple vena contractors?
I could give you the politically correct answer, and then I'll give you my answer. We don't do vena contractas for diagnosis of severe regurgitation, moderate regurgitation by transesophageal echo. We do it with transthoracic echo, and transthoracic works very well. But if you are doing a TEE, it takes no more than a minute to turn the color on, do exactly what you would do on a transthoracic echo, but our preference, because of the protocols that we are involved in, both the tricuspid protocol and the mitral protocol, we get a full volume, and the full volume of the jet then allows just the baseline, adjust the clarity, and look at everything. And with the full volume, you can also subtract the color and know exactly where to put the cursor. So we do full volume. The filter setting, I can't remember. It's an automatic, at least on the two machines or the two brands that we use, the two most popular brands. It's an automatic filter setting, but it's a full volume. The beauty of full volume is, even after the fact, if you need to turn down, because it's a digital full volume, so you can change the filter, you can change the gains, you can do a lot of manipulation. So we do obtain it during 3D TEE, one full volume, which has color.
Okay, Bijoy. I guess we have almost come to the end of the session. So we spent a lot of time answering many of the queries from the viewers. And thank you, Bijoy, for a great presentation and some great tips. And definitely, including me, we all have benefited from this. And it is a Sunday for you, Sunday morning. And generally, as you said, that you sleep a little late, we pull you out of bed a little early. Thank you so much for time and again. You've been there for whatever the Academy requests you for. Thank you so much for the support. And on behalf of the viewers and Indian Academy of Echo, thank you very, very much for this presentation and the time spent on answering the queries from the viewers.
Satish, thank you very much for involving me. It's always a privilege and an honor to be there. And I'm doing nothing. I'm learning more from all of you than I am teaching something, and half an hour early doesn't make a difference. I was awake throughout the whole presentation and question answer. So,
okay.
And all of you have a good night wherever, whatever part of India you are in, and stay safe.
Thank you. So have a good day, great day, and good evening to and good night to all of you viewers. We'll